are very high percentages in each patient group. If a patient has PMR, they're more likely to have GCA. If a patient has GCA, they're more likely to have PMR. So there has been a hypothesis as to whether or not they may actually be the same condition or different manifestations of the same condition. Some other signs and symptoms that can occur in GCA include jaw claudication. So jaw claudication is going to be a jaw pain. This is going to occur in 40% of patients. It's a discomfort or fatigue of jaw muscles. So it can occur after eating or talking. And this is actually going to have a very high predictive value, in fact. So if a patient has jaw claudication, they have some of these other symptoms we talked about before, like a headache, this is actually going to be a very important finding to recognize. And in some patients, they may have tongue infarction. So there may be some cessation of blood flow to the tongue. So that would be where the tongue becomes infarcted. And that's actually going to be pathognomonic for GCA. So if they have tongue infarction, they automatically are diagnosed with this condition. Visual disturbances and visual loss can also occur as well. We talked about the ophthalmic artery being involved. This is actually going to be an important preventable cause of vision loss that can occur rapidly over the course of 3 days. This is going to be, again, a very important finding to look out for. This is going to be something that may initially be a transient visual loss, but it may rapidly progress to permanent visual loss. And it's going to be painless. It's going to be a painless visual blurriness or vision loss. And this can affect up to 50% of patients as well. Now we can also see a tenderness of the scalp in GCA. We can also see cough and sore throat. This can occur in 5 to 10% of patients. And then some other less common findings can include limb claudication. So that is, again, that discomfort and fatigue of the lower limbs. This can be something that can be found in those that have iliac artery involvement. Transient ischemic attacks, or TIAs, can also occur. We can see scintillating scotomas occurring, so that's a visual disturbance. Carpal tunnel syndrome, diplopia, ptosis, and hearing difficulties. These are all potential findings in GCA as well. These are going to be less common than a lot of the ones we talked about before. So diplopia is going to be double vision, and ptosis is going to be drooping eyelid. Now let's talk about how a clinician diagnoses this condition. So if a clinician sees a patient that comes in with these signs and symptoms, especially the headache, the jaw claudication, the visual loss or visual disturbance, it's going to be very key points to make note of when we see the patient. So what the clinician is going to do is that they're going to do blood work. And what they can see in blood work is that there's an increase in acute phase reactants. This is going to be a hallmark finding in GCA. So acute phase reactants are going to include ESR, or erythrocyte sedimentation rate. It's going to be high in GCA, and in GCA, ESR is going to be equal to or greater than 50. And we're also going to see high C-reactive protein, or CRP, and this is not a very specific measurement, but if it is negative, for instance, if we were to actually see a patient that we suspect has GCA, that we check their C-reactive protein, if it's negative, if it's very low or normal, that has a negative predictive value. It makes it very unlikely that the patient actually has GCA. So they're going to have high CRP, and if they have very low CRP, that can often be an indication that they don't have GCA. We can also see thrombocytosis, so high platelet count can be found in this condition as well. And then some other markers that can be elevated include alpha-2 globulin, fibrinogen, and interleukin-6. Now, what's going to be very important with regards to GCA diagnosis is going to be a superficial temporal artery biopsy. This is the standard diagnostic procedure, although not all cases will be diagnosed in this fashion. So what can be noted on this biopsy is vasculitis, granulomatous inflammation, mononuclear invasion, and presence of those multinucleated giant cells. And besides the biopsy, another method of diagnosis can involve color duplex ultrasonography of the superficial temporal artery. And again, these diagnostic methods are only going to be applicable if the superficial temporal artery is involved. But as I mentioned before, it's often characteristically involved. If we were to actually do a color duplex ultrasonography, we can see what we would call an observation of a dark halo around the vessel. This is the classic halo sign. Now, other imaging modalities may be used. These can include MRI and MRA. So MRA can be used to assess the scalp vessels. So this can especially be utilized in patients that have scalp tenderness. A PET scan with 18-fluorodeoxyglucose, or FDG uptake, and then a CTA as well. So these are some diagnostic methods and procedures, but there is a diagnostic criteria. In fact, there are multiple diagnostic criteria for this condition. One of them is one I have here, which is adapted from the American College of Rheumatology. This is their diagnostic criteria for GCA. So their diagnostic criteria involves 1, that the patient is greater than 50 years old, 2, that there is a new headache that is localized, 3, that there's tenderness to palpation over the temporal artery, 4, that ESR measurement is equal to or greater than 50, 5, that there's a positive arterial biopsy result. And with regards to this particular diagnostic criteria, you have to have at least 3 of these. So at least 3 of any of these is enough to say that the patient has GCA. And once GCA has been diagnosed, it can be subdivided into cranial GCA and large vessel GCA. Cranial GCA involves the cranial vessels, but large vessel GCA involves the large vessels, so the aorta and subclavian arteries. The large vessel GCA is actually something that occurs more frequently in female biological patients. So 88% will have large vessel GCA, whereas male patients are more likely than female patients to have cranial GCA. So I want to mention that here as well. Let's talk about the treatment of GCA. Once a clinician has made the diagnosis, how do they treat it? So what's very important with regards to treatment of this condition is high-dose corticosteroid therapy. So this can involve either oral prednisone, 40 to 100 milligrams per day, so these are very high doses, or IV methylprednisolone. So if they're in hospital, they can be on IV steroids. High-dose corticosteroid therapy is extremely important as it reduces the risk of vision loss. So this is why high-dose corticosteroid therapy is so important, to reduce the risk of vision loss. Because what can happen is if these high-dose corticosteroids are started fast enough, there is a 22-fold increased chance of improvement of vision if steroids are started the first day of visual symptom onset. And as mentioned before, visual damage and visual loss can occur rapidly, and it can become irreversible if left untreated for greater than 48 hours. Now, that's why clinicians may see a patient that comes in and they may only have a few of the symptoms we talked about, but it may be enough for the clinicians to be suspicious of GCA. And even before getting a full diagnosis, they may not go through biopsy, they may not do those imaging that we talked about before. They may start the patient immediately on high-dose corticosteroid therapy if they see a patient with visual disturbance and some of these other symptoms, simply because starting the high-dose corticosteroid therapy as fast as possible is going to reduce the risk of vision loss. So that's why some clinicians will just jump to treatment of this condition with high-dose corticosteroids before getting a full diagnosis, especially if they have visual symptoms. So once the high-dose corticosteroid therapies started, the systemic symptoms will be the first to improve. They often improve within 72 hours. Those are going to be the fatigue and malaise and some of the other ones that we talked about before. And what will be important with regards to treatment is that clinicians will continue treatment until symptom resolution. And treatment may occur for many years. And then once a patient has been on corticosteroids for so long, they have to slowly taper to allow their hypothalamic pituitary adrenal axis to start to respond back on its own. Now, another possible treatment that can be used in some patients is low-dose aspirin, or 81 milligrams. There is some evidence showing that low-dose aspirin can reduce risk of vision loss and thrombosis, so I just want to mention that here. But it's not going to be the hallmark treatment of this condition. It's going to be the high-dose corticosteroid therapy. And then some other corticosteroid-sparing treatments can include the immunosuppressants like azathioprine, methotrexate, and cyclosporin. These can also be used for some patients with GCA as well. And then the last treatment I want to mention here is a potential newer treatment known as an interleukin-6 receptor blocker, which is tocilizumab. So we didn't mention this with regards to the pathophysiology of this condition, but interleukin-6 seems to play a role in the pathophysiology. We did mention this briefly when we talked about the diagnosis, when we said that we can see higher levels of interleukin-6. So that's why we may see some newer treatments for this condition involving IL-6 receptor blockers like tocilizumab. So I want to mention that here as well. If you want to learn more about other rheumatological conditions, please check out my rheumatology playlist. And if you haven't already, please like and subscribe for more lessons like this one. Thanks so much for watching, and hope to see you next time.